Hello and welcome to the Recovery Channel. I'm Dr. Richard Whitney, Medical Director of Addiction Services at Shepherd Hill in Newark, Ohio. We're here to talk today about optimizing care and minimizing relapse in opiate-addicted patients. Opiates, of course, are an extremely commonly used and abused, misused, and addictive drug that are ever present in our society today. And I can tell you in Ohio, we have an epidemic of opiate addiction at this time, which makes this topic very topical. Of course, we are talking about primarily substances that are grown in the friendly country of Afghanistan. This is a poppy plant, and the juice that you can see is poppy juice from which opium is extracted. And from that opium, a number of different substances related to opium, thus called opiates, are produced. Now, this has been in our society and other societies for 6,000 years that we know about. People very early on found that the poppy juice was very successful in relieving pain and inducing sleep. In 1805, morphine was synthesized from opium. Morphine is named after Morpheus, the god of sleep. 1874, heroin, named after the German word for heroic, because it was felt to be a wonderful pain-relieving medication without the potential for causing addiction. Of course, we certainly found that that was not the case. Later, synthetic opioids that we'll talk about tonight and during this presentation, as well as the endogenous opiates which occur in the central nervous system that we're born with, that we all can feel during the runner's high. So these products have been, and again, in our society and sometimes in our pharmacies. You can see here what we have is Vaporol treatment from the great city of Kalamazoo, Michigan, which contains 40% alcohol and 3 grains of opium. You can go down to your friendly neighborhood pharmacy and buy this early on in the century before the Harrison Act of 1918. Again, the Bayer company that makes Bayer aspirin synthesized heroin, named it after the German word for heroic, felt to be a wonderful pain-relieving drug, and of course that was quickly displaced because we found heroin is terribly, terribly addictive. In our society, we have a number of different pharmaceutical agents which are synthesized either directly from opium or in the laboratory. Percocet or hydrocodone. Recently, of course, we're coming off of an OxyContin, oxycodone continuous release formulation, now being displaced, at least in Ohio, with heroin. Dilaudid, Vicodin, hydrocodone are very commonly used and misused an addictive drug for healthcare professionals. OxyContin, which was reformulated so it could not be snorted or injected, which led directly to a large amount of heroin being imported into our country, which again is just terribly epidemic. Here we have the kind of routine that a heroin addict would go through here in Fort Myers, but of course any place in the country. We have the heroin being placed in the spoon, cooked down into a liquid, sucked up into a syringe easily obtainable, the vein cut off, and then the heroin injected. Quickly producing a euphoric event likened to an orgasm by heroin addicts, followed by multiple different feelings of relaxation, peace of mind, pain relief, psychic pain relief, and quickly wearing off so that people absolutely have to get their next fix. As tolerance goes up, the duration of the high and the intensity of the high goes down, leading to addicts to use more and more and more. These are obviously active in the brain itself. Most of these are opium-derived or synthetic, produced in the laboratory, which we'll talk about shortly. They relieve pain. They're morphine-like. They hit receptors throughout the brain, indicating their usage in medicine. That means we have pain relief, we have relief of diarrhea, cough suppression, but prescription opioid addiction can occur. We can use opiates intranasally, intralingually, sublingually, orally, transdermally, intramuscularly, and most potently intravenously. This is a picture of the reward center of the brain. This has evolved into the ancient part of our brain from millennia ago. And what we have is a part of the brain that rewards the organism for performing certain activities that enhance survival. Survival are things like drinking when we're thirsty, seeking out food when we're hungry, seeking nurturing and protection with our relatives and other organisms like ourselves, and seeking out a mate and reproducing. And of course, the sex act, drinking liquid when we're thirsty, eating food when we're hungry, produces a surge of activity that makes us just feel absolutely wonderful. That's why it's called the reward pathway. It starts in the ventral tegmental area, sending nervous impulses up to the nucleus accumbens and then up to the prefrontal cortex, eventually hijacking the prefrontal cortex, which is responsible for executive thought, decision making. And as we know, people who are in the midst of addiction do not make good decisions. That's because the desire and the craving for reward supersede the prefrontal cortex thinking, this is what's good for me, I shouldn't spend my rent money on the next heroin fix. At a little more microscopic level, we have a triad of nerve centers, the dopamine terminal, these diamond-shaped objects representing dopamine neurotransmitters, the blue opioid receptors of the postsynaptic cell, and then we have an opiate receptor terminal, and the triad here produces the euphoria produced by dopamine and the intense feelings of pain relaxation and cough suppression, as well as the relaxation euphoric effects of the opiate molecules. So it's a complex interaction that opiate molecules, whether it be diacetyl morphine, which is heroin, whether it be morphine itself, codeine, or a number of other pharmaceutical agents. We can see that opiate receptors are distributed throughout the brain, throughout the cerebral cortex, in the midbrain, and around the reward pathway. And it's in primarily this reward pathway where we get the euphoric effects and the mitigation of psychic pain and physical pain in the cortex of the brain. So these are really active throughout the brain, which is why they have a variety of different beneficial and life-threatening effects. The effects can be pain relief, which is analgesia, of course, sedation, leading to sleep, euphoric effects, which is what really gives people the initial rush when they first take opiates into their system. They feel on top of the world. Constriction of pupils or meiosis, respiratory depression, unfortunately, which can be therapeutically very detrimental to elderly patients or patients who aren't breathing well, and also what leads to the terminal event is respiratory cessation in people who overdose on opiates. Cough suppression can be a therapeutic benefit. Nausea, vomiting is an undesirable side effect. Blood vessel dilation, which leads to reduced blood pressure, is an undesirable side effect. Constipation, which is very common in people who chronically use opiates, as well as itching. The detrimental effects that we hope to avoid but cannot be avoided in drug addicts are sedation leading to physical injury and accidents, overdose leading to seizures and death, especially those drugs like meperidine that have metabolically active and seizure-producing intermediate metabolites. This can lead to overdose, seizures, and death. Malnutrition, intravenous use spreads hepatitis B and C as well as HIV, bacterial infections on the heart valves leading to endocarditis, sepsis, and death, and depression leading to a high incidence of suicide. So we can see these opiates have a wide variety of effect. They're taken for euphoria and pain relief, but we cannot separate these out in the 21st century yet from their undesirable side effects. Now briefly, what's the difference between an opiate and an opioid? An opiate comes from the opium poppy. We get the opium juice and it is chemically separated, synthesized, carbon molecules are added and subtracted. So we have opiates like hydrocodone, morphine, heroin, and buprenorphine. Opioids are those chemicals that have never seen the inside of a poppy plant. They produce pain relief, and they're chemically very similar and sometimes quite dissimilar, but hit the opioid receptors in the brain, producing both the desirable and the undesirable effects. Again, we have natural opioids that are thebaine derivatives such as morphine and codeine, semi-synthetic, which have been altered in the laboratory, oxycodone and hydrocodone being the most commonly prescribed, and fentanyl, pentazocine, methadone, and meperidine, which again have never seen the inside of a poppy plant. We also have a variety of different types of opioid receptors in the brain, mu receptors producing analgesia and respiratory depression, delta receptors, analgesia and euphoria, kappa receptors, pain relief, but also dysphoria. Some people have a predominance of activity of the kappa receptors, and they'll take a Percocet or they'll take a Vicodin, and they'll say, how could anybody get pleasure out of this? signifying the difference between not addicts and addicts' brain. This is not a choice that people make. People are born with a biological predisposition to an abnormal overreaction to drugs like opiates. Now, these are a group of chemicals that are thebaine derivatives derived either directly or indirectly from opium, and will turn an EMET, which is enzyme multiplied testing, that will produce a positive drug screen. These are standard drugs like morphine, hydrocodone, oxycodone, and buprenorphine. The EMET tests are the immunoassay tests, enzyme multiplied immunoassay tests that are commonly ordered in the lab and from a dipstick. Now, the other methadone-like chemicals will not turn a standard EMET screen positive and need a specific test for methadone, a specific test for Demerol. These are important because people can be using drugs other than thebaine type drugs and still have an initial drug screen negative. So pay attention to these if you're ordering drug screens on patients. Of course, we do not have a simple thing of someone beginning to use an opiate and then staying on the same dose and never getting any problems. This is a progressive illness. We start with the use of opiates, we go to misuse of opiates, and then we go to addiction. Why is that? In the early phase, people take their first Vicodin, their first Percocet, very commonly either obtained from a friend or obtained from a physician, legitimately for a broken bone, a sprained ankle, and unfortunately this is how many people get started in their opiate addiction. And people find that they like the effects of opiates. That really makes me feel pretty good. I think I'll take another. I get pain relief and kind of gives me a nice feeling, kind of like a drink used to. After a while, if people use up that prescription, they find that they want a refill on their prescription because they just want that desirable effect even though their ankle is healed. Finally, after a period of weeks, months, and sometimes years, but usually weeks or months, people find that they cannot do without the beneficial effect of opiates because life just does not feel comfortable and pleasant and desirable anymore without opiates. After physical dependence sets in, patient's worst nightmare becomes opiate withdrawal. Imagine the worst case of the flu you ever had, multiply it tenfold, worst nausea, vomiting, muscle aches, joint pain, sweating, tearing, runny nose. It just is an awful experience, and people will do just about anything to get out of it. It doesn't kill you, it just makes you wish you were dead, is a very common statement made from people in opiate withdrawal. Objectively and subjectively, it causes severe symptoms, both acutely and in a protracted withdrawal syndrome. Acute and protracted phases are important to drug addicts because the first initial phase of getting over opiate withdrawal, it lasts 2 days, 3 days, sometimes a week for long-acting opiates. But it can occur even after just a few days or a couple of weeks of opiate use. So patients who are on regular doses of oxycodone, hydrocodone, morphine sulfate can have physical withdrawal symptoms after just 2 weeks of use. Duration of the acute effect, usually 2 to 3 days, sometimes up to 10 days for people who have severe physical dependence and severe withdrawal. But the important thing for healthcare practitioners to remember is this bottom statement: protracted symptoms of opiate withdrawal can last weeks to months, leading to relapse, leading to intense cravings and people desiring to use opiates again. The autonomic nervous system is most active in the opioid withdrawal syndrome. The locus ceruleus releases an abnormally high amount of norepinephrine, produces increase in blood pressure, heart rate, intestinal cramping, diarrhea, nausea, vomiting, sweating, irritability, anxiety, and also feelings of depression, anhedonia or lack of pleasure in life, and intense drug cravings. This can persist for 3 to 6 months, and in fact, this is when the majority of relapses in addiction occur, in the first months of abstinence. People have no pleasure in life. They say, if this is as good as it gets, I might as well go back and use opiates. No decent sleep, stress sensitivity, drug cravings, reduced sexual desire, impotence, and orgasmia. Again, this produces such terrible effects that people say, I might as well go back and start using it because I'm sure not getting any pleasure out of life. So what do we do? How do we treat patients with opiate addiction? That's the key question that we're looking at here. It's not difficult to detoxify patients, but it's difficult to minimize relapse in these patients who are really suffering from protracted withdrawal. Treatment includes a multiplicity of different interventions in our patients. Now, importantly, effective treatment need not be voluntary. Many of us have the mistaken belief that until and unless a patient is ready for treatment and they come in and say, I do not want to use drugs anymore, please put me in a treatment program, that treatment will not be effective. That is not true at all. I have never seen a patient, as a matter of fact, in the last 23 years that came in saying, please take me off of opiates. What they say is, please, I don't want the adverse effects to occur anymore. I'm tired of having a probation officer. I'm tired of going to jail, tired of overdosing, not being able to keep a job. My family's on my case. My kids don't want to be around me. I'm getting HIV infections, hepatitis infections, endocarditis. It's these negative adverse consequences that get people into treatment. Once people are engaged in treatment, it's much more important what happens during the treatment process rather than what got them there. Sanctions actually increase treatment compliance. We love to have family members involved. We like to have probation officers involved because they keep the patient reminded when the going gets tough, if they leave, they're going to have more adverse consequences, so maybe they ought to stick around and complete treatment. And very important to understand is treatment outcomes are similar for those who seek treatment under minimal pressure versus those with a lot of pressure to get into treatment. Less than 90 days of treatment is very, very limited effectiveness in patients with opiate addiction. Without some type of combination of inpatient, residential, intensive outpatient treatment, including involvement in 12-step recovery groups, less than 90 days of treatment has very little effect on the progression of the disease. The relapse rate is astronomically high. Longer treatment is frequently indicated beyond 90 days. We have to have the capability of programs keeping patients involved in treatment, sometimes 6 to 9 months or more, especially people who have relapsed after multiple treatments. There is no single treatment that's right for all individuals. Fortunately, now we have a multiplicity of choices as far as outpatient, inpatient, residential treatment, as well as new medications that can substantially reduce the relapse rate in opiate-addicted patients. We have to address the entire patient, not just the opiate addiction. Sometimes there are co-occurring addictions. Sometimes there are co-occurring behavioral addictions, such as gambling, sexual addiction, eating disorders, health problems, diabetes, family problems, financial problems, social problems. We have to address all these with the individual to minimize the likelihood of going back and using drugs again. In a typical treatment plan, again, it's not just treating the patient for addiction, it's also screening the patient for other co-occurring disorders, assessing the whole patient, getting a complete drug and chemical use history, developing a formal treatment plan, behavioral therapy and counseling, monitoring. Without drug screening, you can never believe whether a patient is completely abstinent or not. The lack of drug screening in programs frequently means that they're going to have a substantial number of people who are still using chemicals. Pharmacotherapy, very, very important nowadays because we have medications that can make a dramatic difference in patients' early sobriety and helping them stay sober throughout the first months and years of sobriety. Case management, aftercare for up to 2 years in our program, and 12-step group involvement. 100% of all of our patients with any chemical use disorder, especially opiate addiction, we get them involved in 12-step recovery groups so they can develop a peer group of sober recovering individuals. The goal of treatment is not just to stop using drugs, although that is the first step, but to return to productive functioning in life. Reducing drug use by over half, reducing crime by over half, increasing the employment prospects. All of these occur with proper treatment, cessation of chemical use, and an attitude change of the patient. This doesn't sound on the surface, oh, only 50% get well, but if you compare it to other chronic, progressive, treatable, but incurable, relapsing, fatal medical illnesses such as diabetes, asthma, emphysema, hypertension, and major depression, we have similar, if not better, outcomes with our patients who are opiate dependent. The basics of treatment have to at least include education. Without a thorough education about the disease of addiction and helping people understand and admit that they have the disease of addiction. They are not bad, dumb, stupid, weak-willed, immoral degenerates like they've been told. They have a brain-based relapsing illness called addiction, and they have to make a self-diagnosis because the doctor or counselor is not going to follow these individuals throughout the rest of their life and remind them they can't drink, they can't take a Percocet, they can't shoot heroin even one time. They have to have a self-diagnosis that they have the disease of addiction. Then they have to be taught to take self-responsibility for self-treatment for the rest of their life because, again, there's no cure for the disease of addiction. We have to teach drug resistance skills. We have to replace drug using activities with healthy activities, help our patients stay motivated to complete treatment, new problem solving skills rather than just, heck, I'm just going to go get drunk and loaded and forget about it. Improve interpersonal relationships, very important because these are relapse triggers, very especially for female patients. So there's a multiplicity of different treatments involved. Does AA and NA really work? The answer is absolutely. There are clinical studies that have shown that number of meetings, frequency of meetings, and how people get involved in 12-step groups have a direct linear outcome in how well patients do in recovery. If people actually have a sponsor, read the literature, work the 12 steps, and get involved in service work, then the recovery rate escalates substantially. Clinically, if you have a patient involved at the very least weekly, although 3 times a week is optimal, then we have a substantial retention rate and a very respectable abstinence rate of at least 75% for those who get involved at least in weekly meetings, and hopefully more than that. Now, is it really cost effective to treat people with this chronic relapsing illness? The answer is absolutely correct. Unfortunately, our legal system, which is primarily interested in punishment rather than treatment and rehabilitation and prevention of future crimes, is a very ineffective way to treat the disease of addiction. Plus, at the cost of no less than $20,000 and probably upwards of $30,000 to keep an individual incarcerated in a penitentiary for a year, rather than an investment of half that much or less in good quality treatment, we can bring about much, much, much better results without disgracing someone, have them have a felony charge on their record for the rest of the year, for the rest of their life, and make them almost unemployable. Every dollar invested in treatment yields up to $7 in reduced crime-related costs, incarceration, police time, arrest, victimization, and so forth. So it's one of the best investments we can make. And it can improve that savings up to $12 for every dollar invested when you include healthcare costs, reduce overdoses, emergency department visits, altercations, fights, falls, motor vehicle accidents, HIV infections, hepatitis infection, and so forth. Reduced interpersonal conflicts, child abuse, and spousal abuse, improves productivity in the workplace, and fewer drug-related accidents and injuries. So if we simply look at it as how much bang am I going to get for a buck? Am I going to waste $20,000 or $30,000 locking someone in a cage with rapists, murderers, and thieves? Or can we invest that money in our population and have a much better return on investment and much better improvements in society than simply locking people away in a cage? What factors predict a higher likelihood of treatment success? Obviously, support from family and friends. Many people enter treatment still with an intact family or at least a supportive family and good, sober friends to support them. This obviously bodes well for long-term success. Good medical insurance and financial resources are very important. Unfortunately, we're diverting a lot of our tax dollars to policing, incarceration, interdiction that really produces very little interruption in supply. It simply raises the price of the drugs that still get through. If we can invest that money in our population, I think we'll get much better bang for the buck. Pressure to stay in treatment. Probation officers, family members, you're going to stay in treatment or I'll fire you. You're going to stay in treatment or I'll divorce you. You're going to stay in treatment or I'm going to put you in jail. These are good motivators to help people stay in treatment, complete treatment, and predicts good treatment success. Motivation to change generally comes after someone begins treatment. Patients very commonly have no idea what life is going to be like clean and sober, but after a period of time and working with counselors and working with other patients who have been sober for a while, people can say, well, maybe I'll just go ahead and complete this process because these people that aren't using drugs anymore seem a lot happier than I was. And good outcomes are very contingent on adequate lengths of treatment. The longer the patient is involved, the better the outcome. And again, remember that key 90 days of treatment is what brings about optimal results. If appropriately given, treatment can be very, very effective and very cost effective. Treatment is effective in producing indefinite remissions in the disease of addiction. It reduces medical costs, health problems, the spread of HIV and hepatitis and other diseases throughout society, minimizes family disruption, fewer kids that have to be on AFDC and other government support systems and then grow up into a life of crime themselves, reduces economic damage, reduces crimes such as muggings and burglaries to get money for drugs, and reduces absenteeism and increases job productivity. There's virtually no downside to engaging someone in treatment. There's every upside that you can think of. Now let's talk specifically about recent advances in medication-assisted therapy for opiate addiction. In my field, this has been extremely exciting. The last 10 years have brought about dramatic advances in medication for substantial improvements in outcomes for patients with opiate addiction. Now, why is this even controversial in the year 2014? We know insulin is not controversial. Antibiotics are not controversial. High blood pressure medication is not controversial. Well, why is medication still controversial? Unfortunately, the treatment centers, who are by and large staffed with a high percentage of people who are in recovery, have an anti-medication bias. By golly, I didn't need medicine. All I needed was the 12 steps. Why should they have to get medication and not do it the hard way? Well, we use better high blood pressure medications, better antibiotics. We treat patients very differently surgically, get them out of the hospital. Why not let this improve our patient's outcome? We're not saying take medication and not go to AA and not complete treatment. Just complete treatment, go to the 12 steps, and this medication can very much help reduce cravings and improve outcomes, which is what we're after. Some people, even in the addiction field, say, well, it's a crutch and substituting one drug for another. Well, if I had a broken leg, I wouldn't mind using a crutch. I can look at insulin as being a crutch for my diabetes and be very grateful I have it. So a crutch it's a pretty good analogy, and I don't mind using a crutch for a while. And it is not replacing one drug for another any more than using asthma inhalers or using high blood pressure medications. And even if it is for a period of time, I can think of little more harmful than injecting dirty, contaminated, hepatitis-ridden drugs into one's veins over and over again until death occurs. And death really occurs at a very, very young age. We are losing a substantial proportion of our young generation who are using injectable drugs. Now, the scientific literature is not even in question and has not been for years. There's an abundance of scientifically produced, statistically significant medical literature documenting the beneficial effects of medication-assisted treatment. Pharmacotherapy is becoming the standard of care in treatment with drug addiction. Philosophies that oppose drug use hopefully will quickly fade into the background as being outdated. Scientific evidence clearly demonstrates not just the short-term benefit, but also the long-term benefit in treating clients with addictive disease. And should we as clinicians promote the optimal outcomes, balance of the literature clearly supporting medication-assisted treatment, reduce criminal behavior, reduced spread of infections such as hepatitis and HIV, back to work earlier, maintaining families, improve physical health. All of these have been shown very clearly with the medical literature and using medication-assisted treatment. Basically now in 2014 we have two basic types of medications. One is agonist therapy, the other is antagonist therapy. And agonist therapy, of course, are those medications such as buprenorphine, such as methadone, that not only cover the opiate receptors in the brain, but also stimulate them either mildly or moderately. That means there is an opiate effect that produces some mood alteration with respect to methadone, minimal or no mood alteration, but the opiate receptors are activated, which means it may produce physical dependence and withdrawal when the drug is withdrawn. It can be used with ongoing opiate use. It's not a complete blockade against using other opiates. It mildly reduces heroin reinforcing behaviors, and it does not have broad public appeal yet. Some people do not believe that methadone and buprenorphine should be used in opiate-addicted patients. That is outdated treatment, and we hopefully will be able to reduce that as time goes on. We also have antagonist therapy, specifically generic drug naltrexone in different formulations, both oral and injectable, that has no negative perception whatsoever in the legal or medical community. It does alter the effect of other drugs such as alcohol in reducing cravings. It also has very favorable long-term outcomes. It has absolutely no addiction whatsoever, euphoria, withdrawal, or potential for physical dependence. So there's very little argument in those patients who choose to use, or whose clinician chooses to use antagonist therapy. And again, this drug naltrexone completely blockades and prevents any opiate from stimulating the opiate receptor in the brain. So agonist versus antagonist. In the antagonist group, again, essentially we have one molecule that works extremely well over the long term, and this is naltrexone. This can be taken orally under the brand name Revia, most commonly under a generic now, and very importantly, a wonderful new injectable once-a-month medication of slow-release naltrexone called Vivitrol, which we'll talk about at length today. We also have two primary agonist therapies that are FDA approved for opiate agonist treatment of opiate addiction, methadone and buprenorphine, the most common brand name of which is Suboxone. Let's first talk about our antagonist therapy. Again, no argument about this. Police love it, judges love it, patients like it, healthcare professionals have no problems with it. Most treatment professionals have no difficulty with naltrexone. This is a synthetic drug. It's not derived from opium, chemically very similar to oxymorphone, brand name Dilaudid, and no opiate agonist effect whatsoever. Essentially what it does, it goes into the brain, it covers the opiate receptor, holds on very tightly, and any other drugs coming in trying to displace it and produce an opiate effect like heroin or morphine will have no effect whatsoever. If a patient is already physically dependent and or addicted to opiates, then what the naltrexone will do is displace the opiates and put the patient in instant withdrawal. So we have to be careful of that before we administer our first naltrexone doses. It's available as 50 milligram oral tablets. These are very effective except for one key problem. Patients don't take them very often unless they're supervised because they don't get any benefit from it except not using opiates. Again, if people are physically dependent on opiates, then one single dose of naltrexone can put them into withdrawal. But 50 milligrams of naltrexone orally per day will block the effects of up to 25 milligrams of heroin, and 100 milligrams will block all opiates for up to 48 hours. So effective, but only if the patient actually swallows it. This is a picture of brand name Revia, also available for reduction in cravings in alcoholics. That's not the topic of our talk tonight, but this is a very effective medication, especially in patients who are dually dependent on alcohol and opiates. You get a twofer for one pill. This is the newest medication out. 100% of the world supply is made here near Dayton, Ohio, brand name Vivitrol, but again, it is naltrexone for extended release injectable suspension. And this is a drug that is really revolutionizing the treatment of addiction in a high proportion of patients. If we look at a cartoon or a drawing here, looking at an opioid receptor in the brain, of course here we have the cell membrane in the brain, and we have opiate receptors looking for these little green-looking heroin or morphine or codeine molecules that when they trigger the mu-opioid receptor, we get an excessive stimulation producing a large amount of electricity that patients liken to a sexual orgasm. This is a euphoric effect followed by hours of relaxation, peace of mind, and when that wears out, the patient intensely craves other effects like this. As tolerance builds over time, patients have to take more and more and more opiates more and more and more frequently to try to get the desired effect, and eventually they get very, very, very weak discharges here, and patients are always chasing that first orgasmic high, but it takes more drug more frequently to produce less effect, and that's called tolerance, which is unique to patients with addiction. Now, if we add a naltrexone molecule, looks like a strawberry here, think of it as a plug. The naltrexone plugs that opiate receptor, preventing any molecules of heroin, morphine, codeine, Dilaudid, oxycodone to get into that receptor. And you see there's no electrical discharge here whatsoever. There's no positive reward at all for the drug naltrexone. It looks like Dilaudid, but it doesn't act like Dilaudid. So when you have an opioid injected or swallowed or snorted, this green grape of codeine or morphine, the red strawberry naltrexone completely blockades the opiate receptor down here, and you get no beneficial effect whatsoever. So why should I bother to take opiates if I'm not going to get high from it? What this is, Vivitrol, are microspheres, polysaccharide microspheres. Think of them as starch balls. And we eat starch, we eat bread. So it's a little bread ball, which is impregnated with these little red naltrexone molecules all throughout the interior. And as this blue starch is gradually absorbed by the body after an intramuscular injection, then the molecules of naltrexone are released into the bloodstream and are taken throughout the body, especially to the opioid receptors. So here are the molecules being slowly released, and you can see the polysaccharide spherule getting smaller and smaller and smaller over the course of a month, releasing a regular gradual dose of naltrexone. So in a month, instead of taking 50 milligrams daily, which is 1,500 milligrams, we have a single 380 milligram dose lasting throughout the month. So we have a lower total drug dose. We eliminate the first pass effect, so there's much less effect on the liver. There is a black box warning on naltrexone, but hopefully that'll be relieved soon because there's no first pass effect from the injected form of Vivitrol. Now, what candidates are good potentials for using naltrexone therapy? Well, patients who are unable or for some reason to take opiate agonist therapy. In some states, physicians cannot be treated with opiate agonist therapy. People who have a high degree of motivation and simply do not want to be placed on opiate agonist therapy. Pilots who cannot be on any mood-altering substance whatsoever. People who are successful on opiate agonist therapy but say, I'm having side effects, I'm having chronic constipation, I just want off my opiates, I want an alternative therapy. Naltrexone is an excellent option for those individuals. People who have been unsuccessful on methadone or buprenorphine opiate agonist therapy are also good candidates for naltrexone as a second option. People who continue to use heroin and other opiates or who frequently relapse on alcohol, a very common effect. Well, I can't use opiates, but I can drink. Patients who are on naltrexone have markedly diminished cravings for alcohol as well. Patients who did not improve on opiate agonist therapy or dropped out of treatment, people who detoxify easily but relapse easily on opiates, or patients for whom a disaster would occur should they relapse. If you relapse, you're going to lose your medical license. If you relapse, you're going to lose your ability to be a pilot. If you relapse, you're going to prison for 10 years. So catastrophic, absolute abstinence needed individuals could do very well on naltrexone therapy. People who are also at elevated risk for relapse. Look, I have to go to my old job. Everybody on the line uses drugs. I'm going to live in my old neighborhood. Everybody there is using. I really need something that's going to maintain absolute abstinence. And perhaps people with a short history and a lower duration of use could do better rather than placing them on opiate agonist therapy indefinitely. Perhaps naltrexone therapy can be a superior choice. Now, who is not a good candidate for naltrexone therapy, either oral or injected? Well, people who frequently overdose, especially after detoxifications. There's a theoretical possibility that a large amount of opiates can overcome the blockade of naltrexone. People will keep injecting or using opiates until they stop breathing before they get high. This is, in my understanding, not been reported yet, but theoretically it is possible. So people who get right out of treatment immediately inject heroin or take a large overdose of opiates should potentially not be initially started on naltrexone therapy. People with serious psychiatric or sociological problems that are going to likely prevent them from being regular attendees at clinics where they can get their oral medication or get their monthly injections, or people who have chronic pain disorders, chronic skeletal pain, chronic pancreatitis, Crohn's disease, ulcerative colitis, that might periodically legitimately need opiate agonist therapy, need some morphine, need some Dilaudid intermittently, then those would be poor candidates. And people with advanced liver disease, probably 3 times or greater elevated liver enzymes, cirrhosis, progressive liver illnesses, probably should not be placed on naltrexone, especially oral naltrexone. Now, what we need is a patient who's been completely, absolutely abstinent from all opiates for no less than a week, optimally 10 days. If you give the initial oral naltrexone or the initial injection of naltrexone, they still have opiates, they're still physically dependent. You put them into instant withdrawal, they're not going to die, but they're not going to trust you. And so we've lost our ability to engage that patient in treatment and say this is a safe, effective medication with no side effects. You want to make sure that they don't have side effects of withdrawal. We need to be careful with patients who have been maintained either on methadone or buprenorphine. We usually have to wait at least 10 days, preferably 2 weeks, to make certain that these medications are out of their system where we can put them into withdrawal, because you will have precipitated withdrawal if treatment starts too early. We need to talk to patients about what happens if they overdose, what happens when they need pain medication. We need to explain this fully to the patient before they take the first injection. What about patients who have legitimate pain? They fall down, break their ankle. There are other non-oral medications and other techniques that can effectively relieve pain. Toradol injectable, ketorolac, non-steroidal anti-inflammatory, extremely effective, bioequivalent to 6 to 10 milligrams of morphine sulfate, very effective for relief of a lot of pain. Regional nerve blocks, sometimes high-potency opiates such as fentanyl under the care of an anesthesiology can effectively alleviate pain, such as for appendicitis surgery. The patient can actually be induced into full anesthesia. Under high-dose fentanyl can overcome the blockade. And patients do need to identify themselves with a medical bracelet and or card in their wallet to make sure that healthcare providers who are looking for identification in a non-responsive patient will know that they're on naltrexone therapy. All right, let's next talk about our first opiate agonist therapy. This is methadone. This is a drug that's been around for decades and decades, initially used strictly for pain until about the 1960s, when someone had an idea of perhaps we're not dealing with bad people, but rather individuals with a brain-based illness. And if we saturate their opioid receptors, maybe they won't crave heroin as much. And lo and behold, that's exactly what happened. This is a comic book demonstrating the benefits of Methadone Man and Buprenorphine Babe. Actually, George Soros was the one that funded this comic book. So we're talking about Methadone Man here. This is an orally active, long-acting, totally synthetic opioid that is very, very useful for chronic pain disorder. Recognizes the 60s have the potential to treat addiction and produces tolerance to the effect of heroin and all other opioids. Very potent, very delicate medication to initiate patients on, very powerful, potentially lethal drug, so it has to be used in expert hands. It can be used for detoxification, but we have to have a special DEA license to prescribe it for opiate agonist therapy. Any doctor with a DEA Class II certification can prescribe methadone for pain, but you have to have a special DEA waiver to prescribe it for opiate addiction. Usually starting dose about 30 milligrams. The long-term maintenance dose could be anywhere from 30 to 300 or more milligrams, depending on the individual. People who say, no, we must not use methadone, we must not use opiates to treat addiction, are rejecting the disease understanding that this is a brain-based illness. Substitution of one addictive drug for another is a misunderstanding of this important word right here, addictive. There's a difference between the addiction and physical dependence. Many drugs produce physical dependence. Beta blockers, chronic opioid therapy for chronic pain disorder, diabetes drugs. There are precipitous withdrawal from a number of medications. That is physical dependence. But methadone used appropriately in heroin addicts and other opiate addicts does not produce drug cravings and in fact suppresses drug cravings. Some people say the drug-free state is the only valid treatment goal, and that would perhaps be fine if the patients weren't dying right and left from overdoses, HIV, hepatitis B, hepatitis C, endocarditis. And to me, it's better to be breathing than not breathing. And the drug-free state, unfortunately, is only infrequently obtained, and a much higher percentage of heroin addicts will have sustained recovery and abstinence from heroin with the use of drugs like methadone. We can see here very clearly when you combine methadone maintenance along with counseling and education, we have even a bonus. We have a reduced incidence of drug use showed by the reduced incidence of the number of positive urine drug screens. Crime days are dramatically reduced with using of methadone maintenance in heroin addicts. HIV is much less common in patients that are treated versus those that are not treated. What we are after here is this beneficial therapeutic window where we have craving relief with little or no side effects. This is the goal right in here. Down here we have too low of a dose, cravings. Up here we have too high of a dose, sedation, vomiting, and itching. So we aim for the sweet spot here in this blood level where we have reduction of cravings with no side effects. Now, what about management of pain, anxiety, and sleep in the opiate-dependent patient? Because these are very commonly encountered in every group of patients, including those with the disease of addiction. Well, how do we manage acute and chronic pain in the opiate-addicted patient? First of all, there are differences in physiologic pathways that conduct these nociceptive, painful information in the presence of tissue integrity. What does that mean? What that means is that brains and tissue propagation of information can be very different in opiate-dependent patients in recovery versus those who are not in recovery and those who have never had the disease of addiction. Also, sometimes it's very different even for addicts who are motivated for recovery to tell the difference between what's real, genuine pain and what their brain is telling them, maybe I heard enough to take an opiate. Some identify pain itself with the stress and anxiety that go along with pain as a very significant contributor to their addiction and to relapse. So if we overtreat pain, we can trigger relapse, but very importantly, if we undertreat pain, we can trigger relapse. So dependence-producing medications like opiates can be very helpful, but they have to be carefully monitored by physicians knowledgeable about the disease of addiction and knowledgeable in the treatment of the disease of addiction. And also, very commonly, like I said, some patients who are in recovery misperceive pain and cravings and can confuse themselves. So that's why supporting other aspects of the recovery while a recovering addict is in pain is so very important. Now, these patients feel absolutely pulled in every direction, okay, like a push me, pull you. They say, I want pain relief, but I'm terrified to go back to where I was. So we have to be very careful, reassuring, and knowledgeable about what we prescribe, how long we prescribe it. We have to, in many cases, involve a physician who is knowledgeable and trained in the disease of addiction. We have to reassure our patients, you are not here to suffer any more than everybody else. We are not going to punish you for having the disease of addiction by undertreating your pain. If the patients arrive at the hospital or the clinic or the healthcare facility already physically dependent on opiates, that is not the time to detoxify them. We switch over to safe therapeutic medications, but not detoxify them from opiates at that time. However, if the patient is co-addicted to sedative, hypnotics, alcohol, and other addictive drugs, then we must detoxify them safely from those drugs, just not the opiates, until the pain episode is over. There are non-medical ways to treat pain. Patients very frequently don't know this. Where are my pain pills? And doctors frequently forget there are oral or injectable medication techniques to relieve pain, such as transcutaneous electrical nerve stimulators, regional anesthesia, massage, exercise, stretching, ice, hot packs. All of these can be very effective in treating pain. But we need to reassure our patients that we are going to adequately treat their pain, even those with addictive disorders. In those who are hospitalized, probably the most effective technique is using a patient-controlled administration. This may sound counterintuitive, but patients who do have a modicum of control by pressing the button on a PCA pump oftentimes take less total opiates than those who are watching the clock and yelling for their medication every 4 hours. And by the way, Dilaudid and morphine do not last for 4 hours, so we're setting our patients and our staff up for problems if we write short-acting opiates every 4 hours rather than every 2 hours. Sometimes this can be misperceived as drug-seeking behavior. So sometimes PCA pumps, but also scheduled administration. What does that mean? It means giving opiates around the clock, every 2 hours, every 4 hours, to prevent pain rather than reinforcing the sensation of pain with a blast of opiates. So it's time contingent rather than symptom contingent. And also additional PRN doses until we have a total 24-hour dose. Split it up every 4 to 6 hours, give it routinely throughout the day, and gradually wean the patients off. This can be a very effective technique for a management of acute pain. Also, when patients are in the hospital, make sure we encourage them to get their sponsor and other people from the recovery group to come in and essentially bring an AA meeting to their hospital room. Then these can reduce stress and the sensation of pain. And again, we must address anxiety, depression, and other clinical disease states that frequently co-occur with major injuries and other illnesses that produce pain. Non-steroidal anti-inflammatory drugs are an important class of medications. Many physicians forget that there are 7 or 8 different classes of non-steroidal anti-inflammatories simply included in that umbrella. So if ibuprofen is not effective, that does not mean that Toradol, that does not mean that naproxen or Sulindac will not work. So we have to try a number of different non-steroidal anti-inflammatories before we can say that class is not effective. Parenteral Toradol, either intramuscularly or intravenously, can be as effective as 6 to 10 milligrams of morphine. Celebrex, of course, being a COX-2, stomach sparing, and some of the older non-steroidals and inflammatories can be helpful. Antidepressants can be very effective for a number of different types of pain. What types? Most importantly, the old tricyclic antidepressants. A lot of young doctors are not familiar with these, but essentially Effexor and other serotonin norepinephrine reuptake inhibitors are similar to the old tricyclics without the side effects, but these old tricyclics, if they were marketed today, would not be sold as antidepressants, but they would be marketed as analgesic medication. Pamelor can be extremely effective, as can dazipramine. Dazipramine non-sedating, Pamelor very effectively sedating in patients who need help with sleep. And bring some of these on, you can be very, very impressed at how much pain relief these can bring, especially for subacute and chronic pain, because they take time to build up. The SNRIs, such as Effexor, is excellent for depression. Effexor probably has some mild analgesic effect, but Cymbalta is probably the SNRI most effective for alleviation of diabetic peripheral neuropathy and other neuropathic pain. Maximum recommended dose is 60 milligrams a day. I see a lot of physicians who use 120 milligrams with more side effects and very little extra beneficial effect. Anticonvulsants are an excellent medication in this group of clients. These are, of course, safe, non-addictive medications. They reduce ectopic spontaneous firing of damaged neurons. Neurontin is probably the go-to drug. This is a drug we all want to take with us to a desert island. It has so many different beneficial effects. Non-addictive, non-controlled, excreted through the kidneys, intact, and only brings about CNS sedation, usually in doses in excess of 3,000 milligrams daily. So 300 TID, 600 TID, 900 TID medication can be very effective with few, if any, side effects whatsoever in patients with chronic pain. Lyrica is a newer medication. It's pregabalin. This is a class 5 drug because it was found to produce euphoria and alcohol cravings in recovering alcoholics. I would use this only as one of the last resort because, like I said, it has been shorted. It's shown to have some withdrawal symptoms suggestive of physical dependence and a euphoric effect. Physical counter stimulation such as TENS units, especially for lower back or other skeletal disorders. These could be very effective, safe, no undesirable side effects, and importantly, patient controlled in its intensity. This can be varied by the patient through the day, which gives them a degree of efficacy over their own pain relief. Manual therapies such as massage, physical therapy, these are very underutilized techniques. A good massage therapist or good physical therapist is worth a lot of morphine and has no side effects to it. Neurophysiological effects such as relaxation, guided imagery, and biofeedback, again, markedly underutilized. There are psychologists in just about every community that use these techniques. If we can engage a psychologist, social worker, or therapist that can use hypnosis, conscious breathing, meditation, repetitive vocalization, these can be very effective in pain relief. These are not hocus pocus alternative therapies, but are mainstream chronic pain therapies. So how do we treat over the long term depression, anxiety, and sleep disorders in the addicted population? What we want to do, of course, is avoid addictive drugs. And of all the drugs that we're going to talk about today, this is the most important class to avoid, and these are the benzodiazepines. Xanax probably being the worst effector, alprazolam, lorazepam, and diazepam, short-acting, highly reinforcing, tranquilizing drugs. It is not safe for a recovering opiate addict or an alcoholic, for that matter, to be placed on these drugs. These patients are not suffering from acute or chronic benzodiazepine deficiency. These are potently addictive drugs. What can we use safely? Buspar, SSRI patients, SSRI medications that are excellent for anti-anxiety drugs, or the more potent, newer, stronger acting second-generation antipsychotic drugs such as Resperol, Seroquel can be very effective in alleviating even severe anxiety in the recovering population and will not produce addiction. The old sleepers such as Halcion, Prosom, Dalmane, newer docs won't even have heard of these. These are potently addictive drugs and should never be used in the recovering population. These drugs, heavily advertised on TV, especially Ambien, are addictive drugs. They should not be used in recovering patients. What then can we use? Well, we still want to avoid Benadryl, diphenhydramine. Why would we avoid these in recovering people? Because they're sedating, they are mood altering, they're not addictive, but they will remind the patients of how they felt when they used chemicals or alcohol or opiates. So they should not be encouraged to take anything with PM in them, any Sominex whatsoever. We rely rather on prescription drugs such as Rosarum, 8, 16, 24, or 32 milligrams. These have been tested in recovering people and do not induce cravings. Trazodone or Deseril is probably the most important and utilized drug. Very, very, very low incidence of side effects. Very occasional pre-upism in males. Males should be warned about this. I've never seen a case, and I've used Trazodone for decades. The old tricyclics such as Pamelor or Elavil can be very effective sleep-inducing agents. Remeron, another sedating antidepressant, can be very good for hypnotic medication. Warm milk, good sleep hygiene, sleepy time tea. Melatonin is probably okay, 1, 2, or 3 milligrams. I've never read in the literature or had a patient experience cravings when they've used a small dose of melatonin such as that. White noise in the background. Again, good sleep hygiene, very important for every patient. So what we want to do is open up for any questions at a later date when we're going to have this same presentation live so we can get texted in or chatted in questions. As for right now, I'm going to go ahead and close this presentation. We're going to talk about buprenorphine and other medications in the next lecture so we can have a talk on office-based treatment of opiate addiction. Again, thank you very much for the Recovery Channel.